Hey, how's it going, guys? So, I wanted to do some shorter lectures for y'all, just to kind of fill in any gaps that are missed in class. And I know sometimes the quality of our slides in class is a little bit lacking, so hoping to do some lectures for y'all that are a little bit more concise and to the point. So this one is essentially the airway chapter. It's going to touch on respiration, ventilation. Hope you guys enjoy it. Let me know if you like these. I'll see if I can get us more. So, quick disclaimer, this is for educational purposes only. It doesn't replace your readings, it doesn't replace your book, it doesn't replace anything we do in class. It's just extra. It's just meant to supplement you and help you. Apologize if I say anything correct. I'm using all these slides are coming from they're coming from the pre-hospital trauma life support textbook. I know that that book is mostly about trauma, but it's really concise. It's got great information in the airway chapter, and I think it'll be better for you than coming directly from your book. So we're going to talk about a few different things. The objectives that we're going to hit in this presentation are we're going to review the anatomy of the airway. We're going to talk about the physiology of breathing. We're going to touch on pathophysiology. We're going to talk about doing a good airway assessment, some airway management techniques, and then we'll just touch on some monitoring devices that are important to know. So, supporting a good open airway is one of the most important things that a paramedic does. In our primary assessment, whether we're doing ABCs or XABCDE or March, the A comes almost first, right after controlling life threats or life-threatening bleeding. So it's very important. All of the cells and tissues in our body, they require oxygen for energy. They also require adequate ventilation to get rid of that carbon dioxide. Remember that in normal metabolism, aerobic metabolism, our body uses oxygen and glucose and it makes CO2 and water. So we got to make sure that we're bringing that oxygen in and that we're getting that CO2 out. If we don't maintain that oxygenation and ventilation, it can cause some irreversible harm. So the primary job of our respiratory system is to make sure that we have that oxygen and that we eliminate that CO2. So we can break the respiratory down into the upper and the lower airway. And the structure that splits it in half, kind of, that's our glottic opening or the opening into our trachea. So everything above the glottic opening is considered the upper airway, and everything below the glottic opening, everything below the opening into the trachea, is considered the lower airway. So here are the structure of the upper airway. Remember, that's everything above the glottic opening or above the opening into the trachea. So we have our nasal cavity, and that's going to be kind of around here where my laser pointer is. We've got our oral cavity, which is just the inside of the mouth. Now, the oral cavity is dominated by the tongue. We'll see later that this causes a lot of airway obstruction. We've got our pharynx, which is kind of that lower back portion of the throat here. And the oropharynx is divided into three sections. The nasopharynx, which is just past the nasal cavity. The oropharynx, which is just behind the oral cavity, and then the hypopharynx, which is that lower pharynx area here. Now, some texts you may see them refer to the oral cavity and the oropharynx, and the nasal cavity and the nasopharynx as the same thing. But generally, it's going to be the pharynx is going to be typically more posterior to those structures. We also have the epiglottis, so that's this leaf-shaped structure here. The purpose of the epiglottis is to cover the trachea, so that way when we eat or drink, food or liquids don't go into the trachea. And when foreign substances get into the trachea and down into the lungs, they can do a lot of bad things. They can cause pneumonia, infection, ARDS, bad stuff like that. So we really want to limit anything getting into the lungs, and that's another component of airway management. Okay, so the epiglottis is kind of a floppy leaf-like structure that covers the opening into the trachea. Excuse me. Additionally, we have the larynx. So the larynx is a kind of a complicated structure that contains the vocal cords. So it kind of sits all in here. The biggest thing to know about the larynx is it houses the vocal cords. Okay. So here's the lower airway. Remember, that's everything below the trachea, or correction, everything below the glottic opening. That includes the trachea, the carina, and now the carina is where that trachea bifurcates or it splits in two. it splits into the left mainstem bronchi and the right mainstem bronchi. Okay, so one important thing to note about the bronchi, and you can't really see it in this graphic here, but the right mainstem bronchi is a little bit more vertical in compared to the left. So notice we have our trachea go down, we have our right bronchi, which kind of stays almost vertical, and then our left one, which kind of shoots out. So that's important to know because if we stick an ET tube or any other type of tube or suction or some type of scope, if we stick that down too deep past the carina, past where this bifurcation occurs, it's more likely that whatever we're inserting is going to go to the right side. It's going to right main stem because it's more vertical and it's more in line, okay? It's less likely for it to go into the left. So the main place that you're going to have this come into play at is airway management where you're inserting an ET tube. If you insert your ET tube too deep, it more than likely is going to go into that right mainstem bronchi. So that's why if you intubate somebody, you listen to lung sounds, you only hear them on the right, you don't hear any on the left. The first step is going to be to pull back your tube just a couple centimeters to see if you mainstemmed them. And most of the time, that's what happened. So just recapping, we've got our trachea, we've got the carina. The carina is where it splits in two. It's that Y portion. We've got our mainstem bronchi, our left and right. Now those bronchi, they start branching out like a tree, like an upside down tree. They branch into the bronchioles, and then they finally, at the end of the tubes, they branch into the alveoli, which are these small kind of balloon-like structures. And the alveoli are lined with capillaries, and that's where the gas exchange actually occurs. Now there is a very small amount of gas exchange that can occur in the bronchioles, but in the capillaries of the bronchioles, but a vast majority of the gas exchange occurs in the alveoli. We're going to quickly touch on some differences in the pediatric anatomy. So kids are still human; they're not aliens, but there are a few little differences to remember that can make things easier. Okay, so again, they have some differences. They have a larger head, specifically their occiput, so the back of their head is a little bit larger. That's why when we pad them, we would pad behind the shoulders rather than behind the head like we would in an adult because of that larger occiput. Their tongues are relatively larger compared to their oral cavity, so they're more likely to become obstructed from their tongue. Their epiglottis is more floppy and leaf-like. So essentially, what that is, when that comes into play, is when we try to intubate them with a laryngoscope, we can't engage the epiglottis into the vallecula as easily as we can in an adult. So this is why straight blades or Miller blades are more popular with children because the Mac blades or the curved blades, they can't manipulate the anatomy in the vallecula as well because that epiglottis isn't as rigid or strong as it is in an adult. So that's why Miller blades that just insert directly into the glottic opening and lift it are more common than using Mac blades in children. In children, also, the larynx sits more anteriorly. So when it comes to intubation or advanced airway management, children are more anterior. That glottic opening, the opening into the trachea, is going to set more forward, which makes it harder to see when you're trying to intubate or when you're doing laryngoscopy. Additionally, they have less developed respiratory muscles. Especially infants, they're called belly breathers because their diaphragm does all the work. Those intercostal muscles, they're not well developed. They can't help out very much in ventilation. So that can come into play with kids becoming tired, going into respiratory failure. They don't have the musculature to help them out breathing, so they may tire out earlier than adults. Okay. So getting more into the science of breathing. So ventilation and how we breathe is regulated by the brainstem. Okay, and now that's going to be a function of pH. Uh, Carbon dioxide, it turns into carbonic acid when it's dissolved in water. So a lot of people will say that CO2 is an acid. CO2 technically isn't an acid, but when it's dissolved in water, it turns into carbonic acid. It binds with the H2O. The CO2 binds with the H2O and it forms carbonic acid. Okay, that carbonic acid leads to an acidotic state and it decreases pH. So the brainstem and the central chemoreceptors that are located in the midbrain, they detect that decrease in pH, and that's what triggers the ventilation. Okay, so again, ventilation is primarily regulated by the brainstem. We have our central chemoreceptors, which detect that decreased pH. Those central chemoreceptors are located in the midbrain, and that triggers us to ventilate when that pH drops. Now, we also have peripheral chemoreceptors. They're located in the carotid bodies, as well as the aortic arch, I believe, and they respond to CO2, but that accounts for less than 20% of ventilatory response. So central chemoreceptors do about 80% of the job, and then your peripheral chemoreceptors do that last 20% or so. Big picture, important thing to understand, in a normal adult with normal lungs, carbon dioxide is essentially what triggers us to breathe. Um, Down the line, that carbon dioxide turns into carbonic acid and it lowers our pH, and that is what truly triggers us to breathe. Um, but when it comes to learning the different respiratory diseases, um, you'll learn that, for example, COPDers, they're chronically hypercarbic or chronically have high levels of CO2. So they are concerned that their respiratory drive, and they become desensitized to the high levels of carbon dioxide, and they have what we call hypoxic drive, where their body starts to measure how much oxygen they have rather than how much CO2 they have. But again, big thing to remember, um, ventilation is regulated by the brainstem. It's determined based off pH, and that pH is determined off the CO2. So in a normal healthy person, breathing's based off CO2. In an unhealthy person with sick lungs, like a COPD, it may be determined by how much oxygen they have in their blood rather than CO2. Now, when we breathe normally, we use a negative pressure. Air is sucked in, okay? So the diaphragm is a muscle. It's a kind of a fan-shaped muscle that lies just at the bottom of our pleural cavity, the cavity that our lungs sit in. And when it contracts, it moves downward. Okay, this downward movement, it creates a negative pressure in our torso, and that pressure is negative compared to the outside environment, and that forces air to be sucked into the lungs or drawn into the lungs. Now, it's important to know that this is an active process because that diaphragm has to contract. Anytime a muscle contracts, it requires energy. So since inspiration requires the diaphragm to contract to create that negative pressure and suck air in, that's considered an active process because it requires energy. Now, when we expire or when we exhale, the diaphragm just relaxes. When it relaxes, it moves back upwards and it kind of passively forces the air out of the lungs. So inspiration is an active process that diaphragm has to contract, but exhalation or expiration is um, a passive process because all we do is relax. It doesn't require any energy. Okay. So, and when we inhale, that air that comes in, it's full of atmospheric oxygen. That oxygen in the inhaled air, it diffuses across our alveolar capillaries, and that carbon dioxide that's coming from our blood, it diffuses out of the alveoli and is expired in that air, okay? And remember that gas exchange, the exchange of CO2 and oxygen, that happens because of the law of diffusion, moving from an area of high concentration to an area of low concentration. So the blood that's circulating through our capillaries, that's coming from the venous system, but it's got all those byproducts of metabolism, so it's got a higher level of CO2 in ratio or comparison to the air that we inhale. So that CO2 moves from an area of high concentration within the blood vessel to an area of low concentration in that air in our lungs, okay? And then vice versa with the oxygen. The oxygen's in high concentration in the air that we inhaled, but it's in a low concentration in that blood. So it moves from that area of high concentration in the air to the area of low concentration in our blood. So here's some key terms to understand. So rate is the amount of times we breathe per minute. Tidal volume is the actual volume of air that we inhale. It's measured in mLs or cubic centimeters or cc's. So an ml and a cc is the same thing mathematically. Dead space is the amount of air that doesn't contribute to gas exchange. So essentially what that is everywhere in the lower airway that doesn't have where gas exchange doesn't occur. So for example, the trachea, there's no gas exchange that occurs in the trachea. It's just the airway tube. There are no alveoli in the trachea. Okay. And then in an adult, that's typically 150 mLs. Okay. Now, minute volume, that is the total amount of air that moves in and out of the respiratory tract in a minute, and you get that number by multiplying the rate times the tidal volume. Okay. There's a term effective ventilation. So this is the same formula as calculating your minute volume. You just subtract your dead space. So if the tidal volume is 500 and they're breathing 10 times a minute, you would just subtract the dead space, which is on average 150 mLs. So 500 minus 150 is 350, and then you multiply that times your rate of 10. So your effective ventilation for somebody would be 3,500 mLs in that particular example. Lastly, there's PEEP. So PEEP is positive index expiratory pressure. That's what it stands for. PEEP is just that pressure in the alveoli after you're done exhaling, the pressure in the alveoli at the end of exhalation. So kind of keeps those alveoli nice and open. Naturally, people have 3 to 5. Me or you right now got about 3 or 5 centimeters of water of PEEP. It's important when we ventilate somebody or have them on a ventilator that we ensure there's a PEEP there with either a PEEP valve or a PEEP setting, normally around 5. So here's a little bit more depth about oxygenation or the science of oxygenation. So there's generally 3 phases, or we need 3 things to happen for oxygenation to occur. So there's external respiration. Sometimes this is referred to as pulmonary respiration. It occurs in the lungs, and that is when we have that oxygen that moves from that ambient air or that air that we inhaled into our blood when that oxygen diffuses into our blood. There's oxygen delivery, which is the movement of oxygen to cells, and that occurs via the blood. And you really need 3 things for that to happen. You need adequate cardiac output. That blood needs to be circulating. You need enough hemoglobin, so anemic patients or people in hemorrhagic shock may struggle, and you need adequate oxygen saturation. Okay, so that hemoglobin needs to be adequately saturated. And then we have internal respiration, which is the movement from that oxygen off of that red blood cell into the cell where it can be utilized by the mitochondria so it can make more energy or make ATP. Okay, so internal respiration, sometimes that's called cellular respiration. But this is a little bit more key information about oxygenation. Then getting into the pathophysiology of breathing. So illness and injury, it can affect our respiratory system, and it can prevent oxygenation or the input of oxygen and the removal of CO2. And remember, those are the 2 primary functions of our respiratory system. We need to get oxygen in, we need to get CO2 out. Okay. A lot of things can mess that up. Okay, just hypoventilation or breathing too slow or too little. It can be from like an obstructed airway. Our tongue can be in the way. We could be unresponsive, and we could have fluids or secretions in our airway. We could have a traumatic brain injury that affects our brainstem and our breathing regulatory centers. We could have broken ribs or paralysis that impairs us from using our respiratory muscles or taking big breaths. We could have a VQ mismatch where our demand of oxygen is not met by our demand of blood flow. We'll go into VQ mismatch a little bit more. We could have diffusion abnormalities like pulmonary edema, where the oxygen can't diffuse because the alveoli is full of fluid, or anemia. And remember, anemia, we don't have enough red blood cells, so we may have plenty of oxygen available, but we can't load it onto enough red blood cells. And then additionally, we may have a decreased ability to utilize oxygen from toxins, and that may be like cyanide or carbon monoxide. So a VQ mismatch is just a term for an imbalance between ventilation and perfusion. So you're going to hear 2 terms. You may hear high VQ states or low VQ states. So hypoxemia is usually seen with a low VQ state, and that's generally due to decreased alveolar oxygen levels. So in this situation, you may have like damaged lung tissue, lung disease like COPD or emphysema. You may have aspiration or atelectasis where those alveoli are collapsed. So essentially, because of the lung, the alveoli is not able to effectively help with gas exchange. Okay, so that's that low VQ ratio where you may have adequate blood flow to the lung, but you can't provide adequate oxygen to the blood. Okay, and now Conversely, flip that with a high VQ ratio. Um, Now, a high VQ ratio is when you have plenty of air going in and out of the lung, but you don't have enough blood flow to pick that air up or that oxygen up, okay? So you may hear the term increased physiologic dead space, where the lung is ventilated, but it doesn't have the blood flow to go to it. So this is common. The easiest way to explain this is with pulmonary embolism. So let's say you have a saddle PE that blocks the blood vessels in the entire right lung. Okay, so you can ventilate just fine with a PE, nothing blocking the air from going in and out. Okay, but because that entire right lung has the blood supply cut off, the air, the oxygen that's going into that lung, it can't hop on RBCs because they're not flowing through there. Okay, so essentially now, since that right lung isn't contributing to gas exchange, it's technically dead space now. Okay, so when that oxygen can't hop on that blood because that blood flow is not there, ventilation's fine, but circulation is not. That's a VQ mismatch as well. Okay, so this is a quick summary of VQ mismatch here, and you'll see this a ton when we get into respiratory disorders. So here we're going to get into a quick knowledge check. We went through a lot of heavy sciencey stuff, so um, feel free to pause here, read these questions. Um, if you need to write on the slides, write on the slides. I'll send the PowerPoint as well, so you can take notes on these if you need to, or write these down in your notes. But make sure that you can answer all these 4 questions. Okay. So here we go. We get into the airway assessment skills. This needs to be your bread and butter. You need to be very good at this. Okay. It's important to be able to assess an airway. It's vital. Um, Generally, if your patient's alert and talking, their airway is probably patent. It may not stay that way, but it's a good sign that it's patent right now. Patients with altered level of consciousness, they must be systematically assessed. Okay, see if that airway's open. Look in the mouth for any fluids or solids. Anything, if you need to suction them, if you need to rake any gross solids out, do so. Look for any deformity or swelling of the face, mandible, or neck. Remember that edema or swelling can obstruct the airway. That tongue can swell, the neck can swell. They may have a tracheal tear. They may have subcutaneous emphysema, air filling up. You may feel those Rice Krispies on their when you palpate their neck or their sternum. Listen for any abnormal sounds. You may hear snoring. You may hear gurgling, a sign of fluid or a sign that the tongue is obstructing the airway. A general term is noisy airway. So if you write your reports, or if you're given a report, you can say that respirations were noisy or the airway was noisy. Gurgling, snoring, stridor, for narrowing of the upper airway. And you want to glance down, look for any abnormal movement, unilateral chest wall, flail segments, retractions. These are very simple but effective ways to assess the airway, and they give you a lot of information on what you should do next. So again, maintaining an airway is a top priority. When you look in the mouth, any fluid should be suctioned. Rake those gross solids out. If they got French fries or hot dogs in there, get them out. If you need to use the McGill forceps, that's an option as well. Manual maneuvers are a great first step. Head tilt chin lift for the non-trauma patient, and jaw thrust for the trauma patient. Great ways to help the tongue be moved anteriorly and prevent it from obstructing the airway. Don't forget about your simple airway adjuncts like MPAs and OPAs. MPAs are great for your patients who may have their gag reflex still intact. Obviously, if you have signs of basilar skull fracture, bleeding from the nose or the ears, avoid it. You don't want to place it into the cranium. An OPA is great if they're completely unresponsive, though if they have any type of gag reflex, it's not gonna go well. Remember how to measure them. Corner of the mouth to the ear for the OPA, center of the nose to the tip of the ear for the MPA. Any patient that's not breathing adequately or not ventilating adequately, if they have ineffective rate or depth, you should assist those patients with a BVM. Here's a great, very clean algorithm coming from the PHTLS airway chapter. It starts with your quick assessment. You want to evaluate the airway position, any sounds, any deformations in the airway, and then look for chest rise. Um, use your manual maneuvers, suction and clear the airways you need to. If your chest rise is good, move on to assessing breathing. If your chest rise isn't good, put in an adjunct. Check their breathing rate. If breathing's ineffective, assist them with BVM. Provide high flow option, and then continue your assessment. This is a nice little kind of succinct airway management algorithm here, with just very BLS maneuvers. And remember, this the basics. The basics are what saves the lives here. Basic is better. And then here's some starting to get into advanced airways now. So supraglottic airways, they help keep the airway open and they separate it from the digestive tract. They're a little bit more secure than OPAs or NPAs. They help when you have to bag for a long time, so they can prevent like hyperinflation of the stomach. They're useful when mass seal is difficult, or if you're going to have to bag somebody for a long time. Now they're not definitive, um, and they require that the patient be completely unconscious, kind of like an OPA does. But pros, they can be placed quickly, and they're typically blind insertion, and they can be really nice. Now, a definitive airway is a cuff tube in the trachea that's distal to the vocal cords or past the vocal cords. That provides the most protection. It protects against aspiration. The two types are the endotracheal tube and the surgical crike. The AT tube has traditionally been a gold standard. It's become somewhat contested nowadays. A lot of people are wondering, is it necessary to have a good outcome? Should intubation be de-emphasized? And I completely understand that, but I think it's important. There are times when intubation is the only answer, so you might as well be good at it, right? So here's some general indications for intubation. Now this is straight from the PHTLS textbook. So you have patients who are unable to protect their airway due to altered mental status. Common teaching you'll see is a GCS of less than 8. Now, obviously, this isn't always the case, but especially in the traumatic patient or a patient with TBI, it is a fairly accurate assessment tool. Patients with significant oxygenation problems, patients with significant ventilatory impairment that require assisted ventilations. Prolonged transport times are huge. If we bag somebody for a long period of time with just a mask, we're going to put air in that stomach. We may cause them to aspirate. We may cause some barotrauma to the stomach. So prolonged transport time certainly a good option, or um, a good thing for you to consider reassessing your airway management plan. And then also inability to maintain the airway with less invasive maneuvers. So, if we're unable to oxygenate and ventilate with simpler means, then we have to do what we have to do with advanced airways. Now, as a paramedic, you're going to have to use a total evaluation system or a holistic evaluation system as to whether intubation is appropriate or not. Okay, so you're going to be equipped with the tools and the knowledge, and it's up to you to use your clinical intuition to decide when it's appropriate. Okay. Here's a mnemonic that's used to predict difficult airways. You'll see this on registry tests or any type of test over airway. There's different mnemonics to test for difficult airways. So lemon used to be the old one, and that stood for just look at the patient. The E was evaluate 3-3-2, so 3 in the mouth, 3 from the chin to the neck, and then make sure you had 2 fingers from the leave the thyroid cartilage. The M was for Malampati. You'd have them open their mouth. O was for any obstructions, I believe, and N was neck mobility. But Heaven is much more accurate. Lemon was really for like anesthesiologists prior to surgery. Heaven is a great mnemonic to use in the pre-hospital setting. So when is somebody going to be a difficult tube? Though I think you should consider every airway as a difficult airway. We'll go through this one. So the H is for hypoxemia. So patients who are hypoxic should be resuscitated first. Trying to intubate somebody who's already desaturated is a nightmare. Extremes of size. So people may be so large that they're difficult to manipulate their anatomy to get a good view. In contrast, that people may be so small, neonates would be very difficult to intubate. Anatomic challenges like swelling or perhaps a patient with no chin, or um, somebody kyphosis is one where they have a very rounded spine. Those are all things that can increase difficulty. Having a dirty airway with vomit, blood, or any other type of fluid, um, that can cause your camera on your video scope to get dirty. You'll want to lead with suction like we do in class, salad technique all the way. The E is for exsanguination. So patients who are hypotensive or in hemorrhagic shock, they should be resuscitated, preferably with whole blood before you intubate them. Remember when we start ventilating somebody, when we normally breathe, it's negative pressure. When we ventilate somebody, it's positive pressure. Okay, that's going to reduce preload. It's going to cause the blood pressure to lower a little bit. All right, keep that in mind. And then N is again for neck size and neck mobility. Somebody, a very small stature person with no neck is going to be heck to intubate versus somebody with a longer neck. Um, you can have a little bit easier time using your laryngoscope to visualize those structures. So to wrap it up, Heaven is a great um, tool to predict a difficult airway in the pre-hospital setting. So here we're going to go over some different types of intubation. So um, the most common is oral tracheal intubation. So that's where you place the tube into the trachea via the mouth, and you use a laryngoscope to manipulate that anatomy. Nasotracheal intubation used to be more common, but generally it's no longer emphasized. With the use of non-invasive ventilation like CPAP and BiPAP, there's really no reason to need to nasotracheal intubate anybody. When I say usually, I'm sure that there's one case, or I'm sure there is a time when it's necessary, but generally generally doesn't occur anymore. Video laryngoscopes improve success rate. If you have access to a video scope, you should use it first instead of a manual laryngoscope. Drug-assisted intubation and rapid sequence intubation, they use medications to facilitate intubation. So traditionally, RSI uses a sedative and a paralytic. Um, we are not able to do that in Georgia. We can just do sedation-assisted intubation or drug-assisted intubation. That's where we just give enough of a sedative to sedate somebody enough that we can place an endotracheal tube. Arguably, is less safe, doesn't work as well. But I guess hopefully we can get some legislature change some things and be able to do it safely. But just know RSI traditionally uses paralytics and sedatives, and drug-assisted intubation or sedation-assisted intubation just uses sedatives. So big complications to be aware of. Um, Aside from just misplacing the ET tube altogether, or sticking it in the esophagus, hypoxia and hypotension are two common complications. They occur either during the intubation attempt, or around it, either shortly prior or shortly after. And like we talked about, that positive pressure, normally when we breathe it's negative, but when we ventilate somebody we introduce positive pressure. Um, that can cause some hypotension. Additionally, the medications we give can cause some hypotension. They can cause some vasodilation. Um, and then when we're ventilating somebody with a BVM, even if we're using end-tidal CO2, it's real common to hyperventilate somebody. Even well-trained providers, we're in a high-stress situation, and we start doing things too fast. We start breathing too fast. And hyperventilation, it can cause some cerebral vasoconstriction, and that can be detrimental to TBI patients. Now, you've already heard me say it a couple times, but we got to make sure before we intubate anybody that they're properly resuscitated. Resuscitate before you intubate. All right, you want to make sure that they have an adequate blood pressure before you uh, administer meds and go sticking a tube in their mouth. Okay. A lot of agencies will have a number. For example, Franklin County's is at least 90 systolic. And if somebody is not at least 90 systolic, we get fluids. We can use push dose pressors and blood products if they're a trauma patient. Okay? And then you want to make sure that they're properly pre-oxygenated um, prior to the attempt. So again, at Franklin County, ours is they have to be at least an oxygen saturation of 90%. So if they're not, we use a high flow nasal cannula. We use a BVM with a PEEP valve. We do what we got to do to get that oxygenation there. And additionally, we would leave that nasal cannula that we pre-oxygenated them with. We'd leave it on during the attempt to provide passive oxygenation. Now, a lot of times people kind of confuse pre-oxygenation and passive oxygenation or think they're the same thing, but passive oxygenation stays on during the attempt. And the point of that is it prolongs your attempt before they desaturate. So it gives you more time to do what you need to do. Additionally, you may find that patients who you resuscitate, they may no longer need intubation. They found this out with some trauma patients. So used to say you'd have a trauma patient, hemorrhagic shock, they'd be unresponsive. But traditionally, the thought would be okay, I need to secure this airway. You secure the airway, and then they'd have increased mortality. They may not do well. But now it's, hey, let me get blood products on board. Get the blood products on board, and their mental status improves. They don't need to be intubated anymore. All right, so just a small example. Remember, big picture, resuscitate before you intubate. Now, when we intubate, we have to confirm our placement. We have to prove that the endotracheal tube is correctly placed in the trachea. So kind of in order from greatest to least. So the gold standard confirmation method is going to be capnography, waveform capnography. You also have, capnometry is just the numerical degree. You also have some CO2 detectors like the little paper, but really waveform capnography is going to be the gold standard. Also, you have visualization. So if you are using a video scope, you can have undeniable proof that it's in the trachea because you can see it. And additionally, if your video scope records it, that's another great thing too. And then kind of your secondary things. So you're going to auscultate after you intubate somebody. You're going to listen to the stomach first because if you got air going in there, you need to know it. And you need to pull that tube quick. So you want absent gastric sounds. You want bilateral lung sounds. You want bilateral chest rise and fall. And then misting in the tube is in a lot of literature, but just with the stomach is a very warm, moist environment. So I just don't think misting in the tube is an accurate tool. So I would stick with at least these top four here: waveform capnography, direct visualization, absent lung sounds in the stomach, and bilateral breath sounds, and you should be G to G. So secondly, we have a surgical cric, which is another advanced airway or definitive airway. So this is an emergent airway. It involves an incision into the cricothyroid membrane and then inserting a tube through that incision that goes into the trachea. So generally this is indicated in a can't oxygenate, can't ventilate situation. Through all the other means, you're unable to get this person oxygenated, unable to ventilate them with BVM. It's very high risk, it's a difficult procedure, and it's very stressful. Okay, you must use the same confirmation methods as you would with a regular intubation attempt. You have to prove that that tube is in the trachea. Now, a surgical cric is not authorized in some states, and the alternative to making the incision and inserting a tube in it is to just use a needle and perform a needle cric, where a needle is inserted through the cricothyroid membrane, and then you attempt to oxygenate through that needle or ventilate through that needle. Not as effective, but again, this is a high risk, very difficult, and very stressful situation. Now, these are some common monitoring devices. So you've got pulse oximetry. It measures the saturation of hemoglobin. Remember that it doesn't specifically measure oxygen. It just measures the percentage of the saturation, but not necessarily what it's saturated with. Okay, so carbon monoxide can sneak up on you. Just be aware if you're near a fire or a gas leak that they may be confounding your interpretation. EtCO2, it detects the presence of carbon dioxide in exhaled air. So again, it's the gold standard for ET2 placement. A misplaced tube, it can cause a lot of bad things: hypoxia, brain injury, and death. We do not want a misplaced tube ever. Again, when you intubate, you must prove that your tube is in the trachea and not in the esophagus. Capnography is that graphic representation of exhaled CO2. So ideally, a square-shaped waveform is ideal, and I'll show you some examples of that. And another thing to remember is that a shark fin waveform is a sign of bronchoconstriction or bronchospasm. Okay? So here's some examples of some waveforms. I'll start over here on the top left. So see, this is a good waveform. It's generally a square shape. So it's not going to be an exact square, but it's square shaped or rectangular shape rather. So this is ideally what you want your capnography to look like. And so remember what you're seeing, this is exhalation, okay? So they're starting to exhale, taking a little pause, they're inhaling, exhaling, pause, inhaling, pause. So this person is able to exhale and inhale no problem. So looking down here, here's our shark fin waveform. So this person is having a hard time exhaling, okay? So notice there's never really a baseline here, okay? They're just exhaling, 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 inhale. A little bit of pause, exhaling, having a hard time, inhale, pause. So this person's having a difficult time breathing out, okay? So they have a bronchospasm or some severe bronchoconstriction. Maybe they're a COPD or an asthmatic having an exacerbation. And if we see this, we know we need some bronchodilators on board, okay? So this is a shark fin waveform. It's a sign of bronchospasm. The patient's having a hard time exhaling, okay? So up here, this waveform is pretty square, right? So we want a good square waveform, but we notice we got these kind of tick marks in it, okay? So these are called clefs or Curare clefs. So it's spelled C-U-R-A-R-E. I presume it's spelled Curare. I've never heard anybody actually say it in real life, but these are a sign of like choking or gagging or tracheal spasm. So if you have an intubated patient who is, say you got them on a ventilator or they're intubated, you're transferring them, whatever, you start seeing these ticks in their capnography peaks, then they need more sedation. They're kind of choking or gagging on the tube, so they just need more sedation, or they need paralysis and sedation. Okay, so this is a cleft waveform, shark fin waveforms, bronchospasm, and then this is a nice square waveform. Okay. So we're going to do some application and action. Okay, so I want you to read this kind of case here. So you have a 30-year-old male who was ejected from their motorcycle. They went headfirst into a tree. They're unresponsive. They're breathing 6 times a minute. They're hypertensive, somewhat bradycardic, and they're hypoxic. So 3 questions I want you to think about. And these application and actions are meant to take everything that we had in this PowerPoint, all that sciencey crap, and kind of help you think about why it matters. Okay, so why are they breathing slowly? How does this affect oxygenation, and how can we correct it? Okay, so feel free to pause, take a little bit of time to think about it, and we're going to go over it. Okay, so this patient has abnormal respirations. This is likely due to a traumatic brain injury. Okay, remember that the brainstem helps control ventilation, and trauma to the brain can affect that regulation. Now, remember earlier we talked about some common causes of poor oxygenation. In this case, the patient's not breathing adequately. They're not providing enough oxygen in adequate amounts for external respiration and oxygen delivery. To correct the hypoxia, we should ensure that they have a patent airway, and we should assist their ventilations with BVM and high flow oxygen. All right, so next one, we've got a 24-year-old male who was struck with a baseball bat in the torso. And you kind of notice every time he takes a breath, he's got a section of ribs moving in the opposite direction. That's the rest of his chest. He's breathing kind of shallow, and his lips are cyanotic. So, questions I want you to think about. Why is his chest moving the wrong way or paradoxically? What does his cyanotic lip suggest? And how can we manage him? All right, take some time, pause if you need to. So this patient's experiencing an injury that's called a flail chest or a flail segment. So this occurs when a section of 2 or more ribs is broken in 2 or more places. This creates a small portion of ribs that are completely separated from the chest wall. And remember that normal breathing physiology involves a negative pressure when we breathe in or when we inspire. The chest normally expands during inspiration. This is because that air fills the torso. With a flail chest, the portion of detached rib gets sucked in by that negative pressure, while the rest of the chest expands. This creates that paradoxical or opposite movement that we recognize. Now, the cyanotic lips, that suggests low levels of oxygen in the tissues, or hypoxia. We see in the question that the patient's breathing shallowly. Now, shallow ventilations may not provide adequate tidal volume and oxygen to meet the body's demands. In the patient, they may be breathing shallowly due to pain. Rib fractures suck, they're painful. This patient may benefit from high flow oxygen and pain management. In order to minimize the discomfort from the flail segment, sometimes positive pressure can be useful, and this can help improve those ventilations. Now, some techs recommend assisting ventilations with BVM or even using CPAP. CPAP provides PEEP, and that positive pressure can help stent the lungs open, and it minimizes that paradoxical movement of the flail segment. Well, here's our last kind of scenario. So you got a 60-year-old truck driver with sudden onset shortness of breath and hypoxemia. He reports he's been having calf pain and he just returned from a long haul. What condition should be at the top of your differential? How can this condition cause hypoxia or hypoxemia? And how can we manage it? So take a second, think about the questions, pause the video, and we'll go over it. So due to the patient's recent history, pulmonary embolism should be at the top of your differential. A trucker is usually pretty sedentary, and additionally, this patient's calf pain is suggestive of DVT, a major risk factor for PEs. Additionally, the sudden onset of shortness of breath is consistent with the acute onset nature of a PE. A PE creates a VQ mismatch. The clot obstructs blood flow to a section of lung tissue that is otherwise receiving normal ventilation, and this causes increased physiologic dead space or tissue that doesn't contribute to gas exchange. That tissue in the lung that's not receiving blood is no better than tissue in the trachea when it comes to gas exchange. Management of PEs will involve hospital treatment to either break down the clot, bust up the clot with medications, or to evacuate the clot. In the field treatment should focus on maximizing oxygen, primary assessment interventions, and rapid transport. Here's some I got like 4 or 5 questions I want to go over, and while I do this, I'm going to kind of show you how I answer questions and see if that can help you a little bit. So question 1, we got a patient, he was ejected, struck a tree, supine, unresponsive, snoring. Okay, snoring is a key word. Respirations of 8 per minute. Okay, 8's too slow. I know snoring is bad. I know 8's too slow. What's my initial management? Okay, so answer A, rapid sequence intubation. This patient may be a good candidate for that, but I noticed in the question it said, what's my initial? So I don't think that RSI would be a good initial intervention. So let's see, I'm going to go ahead and cross A off because I don't really like it. Suction, okay, I may, suction may be fine. A head tilt chin lift, I shouldn't do a head tilt chin lift in a trauma patient, so I know that B is not the correct answer. Okay. C, a jaw thrust. I like a jaw thrust. This is a trauma patient. An OPA. Yeah, he's snoring. OPA, get that tongue off the back of the throat. Assist ventilation with the BVM. He's breathing too slow. I do need to ventilate this patient. So far, C looks pretty good. And then D, a surgical crike. Well, maybe. That could be in the patient's future, but remember, we should only do a surgical crike when we can't oxygenate and we can't ventilate. So we haven't tried any of those interventions yet. So therefore, A, or correction, C is going to be our best answer. Okay. When you're doing your test or you're doing your national registry, you may have multiple answers that seem right, but you shouldn't ever have an answer that's obviously wrong. So when you're looking at your questions and your answers, for example, B, it wants me to do a head tilt chin lift. Well, this patient's probably got a head injury. I am not going to do that. So I know that B is automatically wrong. So don't let a question with an obvious wrong confuse you. Okay. So that's question 1. Let's move on to question 2. All right. So you have a medical patient. They're responsive to painful stimuli with a positive eyelash reflex. What simple airway adjunct would best support their airway? All right. So they are responsive to pain. So I know they're not alert. So they're going to need some type of airway management. Positive eyelash reflex. So the eyelash reflex, when you rub their eyelash, the people will twitch their eyes if they have an intact gag reflex. So this patient likely has an intact gag reflex because those nerves are connected. So if I have someone who needs an airway adjunct and they have an intact gag reflex, I'm thinking MPA. Okay, so already A is on my radar. I know it's not going to be B because an OPA is not indicated in somebody with a gag. C, I'm not going to get a supraglottic airway in somebody with a gag reflex. And D, a non-rebreather mask. So D is not even an airway adjunct. So I know that A is my answer. So question 3. I'm assisting ventilations. Having a hard time maintaining a seal. My patient's unresponsive. The hospital is 8 minutes away. Which airway device would be most effective? Okay. Let's see here. So, unresponsive person, they need to be bagged. 8 minutes. 8 minutes isn't that long. And which airway device? Okay. Let's see here. I'm going to go ahead and try to start marking off things that I can't use. OPA. OPA is not a bad option. Not a bad option. Supraglottic airway. That could be a good option as well. I know I can place a supraglottic airway fast, and I know that supraglottics are good if if I'm having trouble keeping a mask seal, and I can insert them pretty fast, and most of them are blindly inserted. So B is a good option. B is a better option than A. Okay. C, intubation. Intubation is a good option, and some may choose to do it. We are close. I'm gonna go ahead and mark off A because I know B is a better answer than A. So I'm gonna go ahead and mark off A completely. And I happen to glance down here at D, a surgical crike. There's no reason to do a surgical crike on this person yet because we haven't tried everything yet. Okay. I'm gonna go ahead and mark that off. So I know either B or C. So I got to determine to myself which answer is better than the other. So an ET tube would be definitive. Okay. But a supraglottic, I'm only 8 minutes away. So it's not prolonged. I can put in a supraglottic faster and blindly insert it. Okay. Whereas an ET tube, it may take a little bit longer time to do it right. It's not blind inserted. So I think the better answer here is B because you can do something quickly that can help you maintain a good seal other than a mask, and it can be blindly inserted. So I think B is going to be our answer here. All right, last question, question 4. You're managing a patient who's experienced severe facial trauma after a self-inflicted GSW. You're unable to ventilate because of the anatomy's been disrupted. They're hypoxic. What management technique should you utilize? So we got somebody with a severe injury to the face. We can't bag them. We're not able to ventilate, and we can't really oxygenate them. So bilateral MPAs, probably not. Severe facial trauma, probably not. Nasotracheal intubation, probably not for the same reason. Orotracheal intubation, or surgical or needle crike. So this would be an extremely difficult intubation, provided that you can even identify the anatomy. And we are in a situation where we can't oxygenate them and we can't ventilate them. So at this time, a surgical airway would be the appropriate choice over oral tracheal intubation. Okay. All right, guys, bear with me. I know that this has been a long one. So in summary, just kind of wrapping up, it's important to have a basic understanding of anatomy. That can bail you out and get you a long way, just having a basic understanding of the concepts. The goal of the respiratory system is to take in oxygen, get rid of CO2. A lot of different illnesses, a lot of different injuries can disrupt that process of happening. Airway management should start simple, things like positioning, suction, simple adjuncts, and assisted ventilation. And then, if needed, things like supraglottic airways, intubation, and RSI can be used if necessary. And then tools like pulse oximetry and end-tidal can be really useful. Lastly, here are the references if any of you want to check these out. The PHTLS textbook is great. It's got a lot of good stuff in it. This Smart Surveyor Art right here, they have free images if you need to do a project or anything like that. You just have to cite it. And then there's where I got the clef waveform from. But I hope you found this useful. Let me know if you have any questions. Appreciate all of you.